Before we start, I'd just like to bring you a quick message from one of our expert speakers at MIMS Learning Live North. That's taking place on 26th of November in Liverpool. This event promises to have our usual lively mix of clinical learning sessions, and Dr. Deborah Kerr, who's a GP in Kings Langley and a GP with an extended role at the National Migraine Centre, is one of our speakers. And she tells us over 10 million people in the UK suffer from migraine, with over 80 million sick days taken every year. The aim of my talk is to give you the confidence to diagnose and manage these patients with clear guidance, including an introduction to the new anti-CGRP medications we now have available in primary care. So that's a quick preview from Dr. Kerr. I'm looking forward to her talk as well as all the others at this not-to-be-missed event. Hello, and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning, and I'm delighted to be joined today by my colleague, Rhiannon Ashman.
Hi, Pat.
Viruses and vaccination are never out of the news, are they, Rhiannon?
They're not, which reminds me, actually, I need to book my flu jab.
Good point. And while opinions on vaccination vary, with some very ill-informed views being put forward, the NHS quietly and steadily gets on with the job of preventing untold harm through its vaccination programmes. I had a brief look at some vaccination schedules provided by our sister publication MIMS, and this reminded me that these programmes are constantly changing. One of these changes is the introduction into the childhood schedule of a routine chickenpox vaccine from the 1st of January 2026. And at the other end of the age spectrum, but with the same virus involved, the shingles vaccination programme has also just changed in September 2025 to encompass more adults. So today we'll be discussing these changes and also the diagnosis and management of chickenpox and shingles, both common conditions linked by a common virus which can manifest in a mild form but also cause serious complications. Let's start with children first. I remember both of my children had chickenpox when they were little, and it was quite a busy time, and my memory is a bit blurry.
I had chickenpox around the age of 2, and I kindly passed it on to my 2-week-old brother, apparently, which must have been an enjoyable experience for my parents.
That's very thoughtful of you. Chickenpox is, of course, caused by the varicella zoster virus, which also causes shingles. We have a clinical review on chickenpox, originally written by Dr. Nuria Martinez-Allier and Dr. Kirsty Ledoir, which looks at diagnosis and management. The varicella virus is, of course, highly contagious, and at the time of recording, we're heading into chickenpox season, because each year a peak in cases is seen in the winter and early spring. Chickenpox is spread by direct contact or by airborne droplets, followed by mucosal invasion of the upper respiratory tract and conjunctiva. A primary viremic phase is followed by a secondary viremia to the skin and mucosal surfaces.
Yeah, so children are contagious from 1 to 2 days before the onset of the rash, till all the lesions have crusted over. Most children usually become ill 14 to 16 days after contact, but the incubation period can be much shorter in immunosuppressed patients. Interestingly, each child in a family who develops chickenpox tends to have sequentially worse disease.
Yes, that I do recall. The first child in my household had a few spots, and the second one had masses of spots everywhere.
It's worse for young infants, adolescents and adults who tend to have more severe disease with a higher rate of complications. And as we'll talk about in a minute, the varicella virus becomes dormant in the body after you've had chickenpox and then can cause shingles later in life. And although you can't get shingles from contact with a child with chickenpox, it can happen the other way around. So a child can get chickenpox from contact with an adult with shingles.
That's fascinating. So staying with chickenpox for a minute, what are GPs looking out for in order to arrive at a diagnosis?
Well, chickenpox is characterised by a generalised pruritic rash that develops into vesicles, then pustules, and finally crusts over. And the rash is seen mostly on the head and trunk, but can occur anywhere, and it appears in crops, with new lesions occurring for 3 to 6 days following the primary lesion. It's usually distinctive, and GPs will try to establish whether there's been a recent exposure to the virus, because that'll be helpful in making the diagnosis.
And are there any differential diagnoses?
Yeah, so according to the authors of the chickenpox review, there are a few differentials to consider, and these include herpes simplex, herpes zoster, hand, foot and mouth disease, enterovirus, impetigo and syphilis.
And who's most likely to get more severe disease?
Well, chickenpox is often considered to be a mild, sort of run-of-the-mill childhood illness, and I remember pox parties from when I was little. But for some, it can obviously be very unpleasant. Immunocompromised children, including those with HIV or those on long-term steroids, can get progressive severe disease. And this would involve a high fever of long duration, continuing eruption of lesions, and the development of complications. And children with chronic cutaneous or pulmonary disorders or those on long-term salicylate treatment are at high risk of recurrence.
So apparently it is possible to get chickenpox more than once, particularly if you're in one of the high-risk groups that you just mentioned. And there is some research highlighting this, which we'll link to in the resources for this podcast.
So how about management?
Well, according to the clinical review, the management of chickenpox is with supportive care, with oral fluids and antipyretics. Ibuprofen is not advised as an antipyretic because of a possible increased risk of necrotizing soft tissue infection and invasive group A streptococcal infections. Salicylates also shouldn't be used because of an increased risk of Ray's syndrome. Calamine lotion or chlorphenamine can be used to alleviate itching. And the only licensed treatment for varicella in children is acyclovir, which can shorten the disease course by approximately 1 day of fever and rash. But the authors of the review recommend it should actually only be given to adolescents and adults, and it has to be given within 48 hours of rash eruption to be effective.
And the advice for community management of chickenpox is that children should stay away from school or nursery until the last vesicle is scabbed, and they shouldn't travel by air either until the last vesicle is scabbed over. So that got me thinking about the potential impact of chickenpox, and there's also a health inequalities piece in here, isn't there, about parents having to take time off work and the associated loss of earnings, which might affect those in lower socioeconomic groups more significantly.
Yes, I guess if you haven't got safety nets of grandparents looking after the children or an understanding employer, it could be really tough.
Those with chickenpox should also avoid contact with pregnant women, immunocompromised patients and infants under 4 weeks old.
Yes, and we'll discuss more about chickenpox and pregnancy in a minute. For now, staying with the childhood angle, it's possible GPs may see fewer cases of chickenpox in future.
Yeah, the routine chickenpox vaccination that you mentioned will start from 1st of January 2026, and children will be offered a combined vaccine for measles, mumps, rubella and varicella, the MMRV vaccine, on the NHS, with their first dose being at 12 months and their second dose at 18 months.
So the idea is to reduce cases of chickenpox, prevent children from getting complications that cause hospitalisation, such as bacterial infection, lung and brain inflammation and even stroke.
Yeah, and interestingly, given the restrictions on social mixing during COVID, there were fewer cases of chickenpox in younger children, which has left a larger pool of children susceptible to varicella. And the US, I was reading, has just gone in the opposite direction to the UK in regards to the chickenpox vaccine, in that they're moving towards restricting access to the combined MMRV vaccination and moving towards separate MMR and chickenpox vaccines.
Oh, that's interesting. So what's the rationale for that?
Well, the US currently offers children 2 doses of MMR and chickenpox vaccines, and for their first dose, they have separate chickenpox and MMR vaccines, unless parents request the combined vaccine. But new restrictions would remove that combined option. And the thinking relates to the very small increased risk of febrile seizure with the combined versus the separate vaccine. But on the flip side, of course, the combined vaccine means fewer injections, fewer appointments, and probably better uptake, which, of course, is really important when it comes to vaccines.
Sure.
So returning to the UK, the chickenpox vaccine itself has, of course, been available for some time, and parents have been able to get their children vaccinated privately.
Yes, I came across the delightfully named Spotty study, which showed that many UK paediatricians pay for the chickenpox vaccine for their children.
Never say that researchers don't have a sense of humour. Yeah, it's an interesting study. And actually, I read that paper when I was considering whether to get my kids vaccinated privately, which I did do, by the way.
So what are the likely effects of introducing this as a routine childhood vaccination?
Well, in the US, as I mentioned, they've had the chickenpox vaccination programme for about 25 years. The Centres for Disease Control and Prevention say that the chickenpox vaccination programme has prevented 91 million cases, 238,000 hospital admissions and 2,000 deaths over a 25-year period.
Wow, that sounds amazing. But wasn't there some evidence that adults exposed to chickenpox are less likely to get shingles? So do we know what's happened in the US in terms of shingles cases? Have they gone up?
Right, so yeah, what you're describing is a hypothesis called exogenous boosting. And indeed, this was one of the reasons why the JCVI, the Joint Committee on Vaccination and Immunisation in the UK, hadn't recommended a chickenpox vaccine programme before now. So, as you said, the idea was that people who have previously had chickenpox have their immunity boosted by exposure to circulating varicella zoster virus, which would inhibit reactivation of the virus and the development of shingles. And the concern was that a varicella vaccine programme would prevent this exogenous boosting and lead to a significant increase in cases of herpes zoster, shingles, particularly in middle-aged adults who aren't old enough to be vaccinated against shingles. But a 2022 study from the US, reflecting on the 25 years of the chickenpox vaccination programme, led to the CDC concluding that fears about increasing cases of shingles as a result of the chickenpox vaccination programme haven't been borne out. And this was factored into the JCVI's recommendation, which they made in 2023, to introduce a universal chickenpox vaccination programme in the UK. And of course, as you mentioned in the intro, Pat, the shingles vaccination programme is also being extended in the UK, which I guess would possibly ameliorate any impact on older adults, at least, of the chickenpox vaccination programme.
That's really interesting. I've learnt something from you looking into that. We'll get on to talking about shingles and shingles vaccination in a minute, but can we just touch on chickenpox in pregnancy?
Yeah, we've got a learning module on this written by consultant urogynaecologist Mr. Majid Abdulrahman, and it's a concise guide to the Royal College of Obstetricians and Gynecologists Green Top Guideline on chickenpox and pregnancy. Apparently 90% of pregnant women in the UK are immune to chickenpox, but considering the health inequalities angle again here, women who grew up in a tropical or subtropical area are less likely to have had it in childhood and thus more at risk of catching it in pregnancy. And getting chickenpox when you're pregnant can be serious, causing maternal morbidity or even mortality. And there's a risk of fetal varicella syndrome and varicella infection of the newborn.
Yeah, and there's a handy algorithm in this learning module which shows how to proceed if a woman presents either having had contact with a chickenpox case or with active chickenpox. And if she does develop chickenpox, she should avoid contact with susceptible individuals such as other pregnant women and have symptomatic treatment.
Acyclovir can be given if she presents within 24 hours of the rash appearing and she's over 20 weeks pregnant, and it can be considered if she presents within 24 hours of the rash appearing and she's under 20 weeks. Those with severe infection will likely need intravenous acyclovir in hospital, while those with an infection at less than 28 weeks gestation should be informed that their infection is associated with a 1% risk of fetal varicella syndrome, and they can be referred to a fetal medicine specialist at 16 to 20 weeks gestation or 5 weeks after the infection.
Okay, that all sounds very clear. Thank you. So let's move on to our clinical review on shingles and post-herpetic neuralgia, which is new at the time of this recording. Shingles happens when the varicella zoster virus resurfaces after a period of dormancy. After you've had chickenpox, the virus enters the sensory nerves, travelling to the sensory dorsal root ganglia, where it then turns into a latent infection. Reactivation of the virus is what is seen as shingles. And at the moment, shingles affects 50,000 people aged 70 or older in England and Wales each year. 10 to 20% of cases involve ophthalmic involvement. 4% of cases have long-term effects. And sadly, 1 in 1,000 cases results in death in the over 70s.
And what symptoms would people usually have with shingles?
It starts with a prodrome, including unusual skin sensations, headaches, nausea, fever, general malaise, and this then leads to the characteristic vesicular rash, itching and or sharp shooting pain. And according to this review, which is by GP Dr. Pipin Singh, it's important to examine, to evaluate the rash, to look for secondary infection, make a focused neurological examination and look for vesicles in the auditory canal. The rash has a dermatomal distribution. There's a nice illustration of the dermatomes in the module, and it doesn't cross the midline. It's important to be aware of potential eye complications, as shingles affecting the ophthalmic branch of the trigeminal nerve requires same-day ophthalmology assessment.
And what are the differentials?
There's quite a lot. These could include insect bites, scabies, localised allergic reactions, drug reactions, impetigo, bullous pemphigoid, Ramsay-Hunt syndrome and eczema herpeticum.
And the rash can be quite long-lasting and painful, can't it?
Yes, the rash can last for 4 weeks and it can be followed by post-herpetic neuralgia, which can last for 3 to 6 months, having a significant impact on patients' lives. 20% of patients will have post-herpetic neuralgia at 3 months and, astonishingly, 15% will have it at 3 years. Treatment options outlined in this module include the antivirals acyclovir, valacyclovir or famciclovir, starting them as soon as possible to reduce the risk of complications. For pregnant women, GPs should seek advice from their local obstetric team. And what about pain relief, Rhiannon?
Well, there are a variety of options, including paracetamol, short-term opiates such as codeine as a one-off acute prescription, neuropathic agents including amitriptyline, gabapentin or pregabalin, depending on your local formulary. Again, depending on your formulary, topical agents such as lidocaine, medicated plaster or topical capsaicin may be another option.
And combining them is a possibility. So we have an interactive case study in this module, and it's the case of Barry, who attends his GP surgery with a painful back. First, you can look at Barry's medical history and the medications he's on a simulated computer screen, and then you move on to a conversation between Barry and his GP. He thinks he's strained a muscle in the garden, but guess what the GP sees when he looks at Barry's back?
Do tell, Pat.
Well, I think our listeners can probably guess where this case review is going, but just to say Barry does have a nasty rash, that the module provides some tips on combining pain relief, and it's fun to work through because it's very pictorial.
That sounds great. And the module talks about the most recent changes to the shingles vaccination programme as well, doesn't it?
Yes, and we said we'd come back to that. So what are the latest changes?
Well, the shingles vaccination programme was first introduced in the UK in 2013, vaccinating people aged 70 and over. And currently it's being offered to individuals turning 70 or turning 65. Immunocompromised individuals aged over 50 were also offered the vaccine. And as of September 2025, all severely immunocompromised individuals over 18 are eligible for vaccination.
So that's good. That means that as time goes on, substantially more people will be spared getting shingles and post-herpetic neuralgia, which sounds very welcome.
Yes, and as we were saying before, the fact that the shingles programme is extending may have contributed to the decision-making around offering the chickenpox vaccine routinely. If you're able to protect adults from shingles another way, then you don't worry so much about them losing the benefit that they would have had from that exogenous boosting that we talked about earlier of exposure to chickenpox.
Yes, that's really interesting. And it'd be interested to see what the effects of the new vaccination schedules will be for both chickenpox and shingles.
Yeah, absolutely.
Just one more thing before we go. I saw an interesting news item from the European Society of Cardiology earlier this year. A meta-analysis showed an association between shingles vaccination and a lower risk of heart attack and stroke. Apparently more research is needed to understand whether there may be a causal connection, but it would be interesting if shingles vaccination had other effects beyond prevention of shingles. Thanks for joining me today, Rhiannon.
Thank you, Pat. I've enjoyed our discussion.
So, what did we learn today? First, the routine childhood chickenpox vaccination will start from 1st of January 2026, with children being offered a combined vaccine for measles, mumps, rubella and varicella, the MMRV vaccine on the NHS. This replaces the current ad hoc arrangements for chickenpox, including people obtaining the vaccine at their own cost. Second, 90% of pregnant women in the UK are immune to chickenpox, but women who grew up in a tropical or subtropical area are less likely to have had it in childhood and they're thus more at risk of catching it in pregnancy. Third, as of September 2025, all severely immunocompromised individuals aged over 18 are now eligible for shingles vaccination. They join those individuals who are already eligible, and at the moment the programme is offering vaccination to people turning 65 or turning 70. Don't forget you can claim CPD certification for listening to this podcast. Simply head over to the version of the podcast on the MIMS Learning website. You've been listening to the Clinical Update podcast produced by Jude Owen. Tune in next week when our medical editor Dawn Powell will be talking to Dr. Steve Brinksman about alcohol misuse. Thanks for listening. See you next week.